Hi everyone, welcome back to another WashU Nephrology storytelling web episode. My name is Tim Yao and I'll be your narrator today. This month, I am presenting the history of the Renin Angiotensin axis, which dates back over 100 years. This hormonal axis is something that is easy to learn but hard to understand, and I hope that with this video and the history, it makes your understanding of the system a bit more clear. So this is the image we're going to start with, which is of Professor Robert Tigerstedt around 1910 at his lab at the University of Helsinki in Finland. Tigerstedt was born in Helsinki and studied medicine with the intent to do research in physiology. He was eventually recruited to the picture on the right, the Karolinska Institute in Sweden, where he worked with Alfred Nobel and was asked to draw up the basic principles for the Nobel Foundation. Eventually, he moved back to Helsinki, but not before making some seminal discoveries. Tigerstedt was interested from a very early age on a renal pressor substance, and he stated, I quote, "As far as we know, no one has yet investigated to what extent a substance influences the circulatory organs from the kidneys. In view of the intimate connection between some renal and cardiac disease, it seems possible to investigate the presence of such a substance." And he was influenced primarily by two scientists pictured here, Dr. Richard Bright in England, who had noted earlier in that century that patients dying of end-stage kidney disease had severe hypertension and cardiac hypertrophy. And another influencer was Dr. Charles Edward Brown-Séquard, often considered the father of modern endocrinology, pictured on the right. In around 1890, Dr. Brown-Séquard, who was in his 70s at the time, had given himself 2 weeks of a subcutaneous injection of guinea pig testicle extract, and the results were, as he quoted, "I have regained my vigor, and all my troubles have completely disappeared." So in the wake of this, Tigerstedt continued along the same vein, investigating injecting renal extract. And he published this work in 1898 titled Nier und Kreislauf, which translates into kidneys and circulation. The basic hypothesis was that a pressor substance was being formed in the kidney and passed into the blood. And to test this, Tigerstedt homogenized fresh rabbit kidney with saline. He centrifuged the material and injected the supernatant fluid into other rabbits. He used a device on the right called a kymograph, which records pressure variations by the trace of a stylus on a rotating cylinder. And he recorded the blood pressure changes after injection of the supernatant, and he noted a rise, first an unexplained biphasic response where you had a dip, but a subsequent rise in the blood pressure. And he noted many other observations which are still true today, which is that there is a pressor substance, and it was identified as a water-soluble protein from the renal cortex and the renal venous blood, but not from medulla or renal arterial blood. And it was confirmed then that this was generated in the renal cortex and secreted into circulation. And he stated, "We wish to call this substance for the sake of brevity by the name renin. And with these observations, we do not formulate a new hypothesis about the interconnection between renal diseases and cardiac hypertrophy. We only wish to draw attention to the possible importance of a blood pressure raising substance formed in the kidneys." So a quick side note and teaching point here is that many physicians will pronounce this substance as renin, according to an informal Twitter poll seen here. More than half the respondents actually pronounced it this way, renin, rather than renin. And I think it's worth pointing out that Tigerstedt named the protein after renal, and it is safe to say, in my opinion, that the correct pronunciation is with a long E, renin, as in renal. So as with a lot of medical discoveries, this discovery of renin was not really appreciated at that time, and the information actually lay dormant for another 30 or so years before another physician pictured here took on some new observations. So this is an image of Dr. Harry Goldblatt, who was a pathologist that noted that many patients who died of complications of hypertension had significant stenosis of the renal artery upon autopsy. And the natural assumption is that hypertension accelerates atherosclerosis, which thickens the vessel intima, subsequent narrowing, so forth. However, Dr. Goldblatt was seeing patients with very normal cerebral and coronary vasculature, but with significant narrowing of the renal artery, and revived the thought of this renal pressure substance that potentially could be the cause of the hypertension. And the animal model of renal artery stenosis is often referred to as the Goldblatt kidney, which I'm going to show you in the next slide. And although this animal model is somewhat difficult to replicate and doesn't actually behave quite like the human disease, it's still useful to understand. So Goldblatt simulated ischemia by constricting the main renal artery with a clamp that could be left in place and adjusted. And unilateral constriction raised the blood pressure, no surprise there. And if you actually removed the contralateral unaffected kidney, or if you constricted a solitary kidney, this lead to very severe blood pressure elevations. Now, what actually surprised Goldblatt was that removing the clamped kidney led to resolution of the hypertension. And again, this demonstrated that there was a pressure substance being created within the kidney that was triggered by decreased blood flow, and the logical substance that was a candidate was renin, as Tigerstedt's experiments also pointed in that direction. However, experiments showed that renin itself is not a pressure substance. If you inject it directly into serum, it doesn't lead to hypertension. And interestingly, the more you use it, the less effective it became, something we call tachyphylaxis. And this is demonstrated here by Dr. Paige. Paige is also known for a kidney animal model, or the Paige kidney, which simulates extrinsic compression of the organ, as would be seen in, say, a retroperitoneal hematoma. And Paige achieved this by tightly wrapping cellophane around the kidney, which also led to release of renin. So Paige followed this work up by further identifying the vasoactive substance using elegant cat models. Renin required a substrate. Here he calls it renin activator, but it is what we now know as angiotensinogen, which is created in the liver. And ultimately, the pressure substance that was formed, he identified and titled angiotonin. Now, in the southern hemisphere at around the same time, a similar approach was being taken by scientists in Argentina using dog models instead of cat. And doing essentially the same experiments, they identified the same substance. Instead of calling it angiotonin, however, they called it hypertensin. And if you notice the dates, we're talking February 1940 and September 1939. These were literally publications that were received within 4 months of each other with virtually identical results. Here you can see figures from each paper showing the blood pressure rise of the animals after injection of the vasoactive substance, again, identified separately in 2 different labs using different animal models. And so you can see where this story is going. Even 70 years ago, I think the lesson is that it's important to publish your research as quickly as possible. Otherwise, you risk being scooped. But there is a happy end to this, as we all know. Ultimately, these 2 authors collaborated and published a letter in Science here in 1958, suggesting that rather than use 2 different names for the same peptide, that the hybrid name angiotensin be adopted. And the authors hoped, I quote the last line, "There will be many who from habit will want no change, but we hope usage will make the heart grow fonder." I think it's safe to say now, 60 years later, that the word angiotensin holds a fond place in the heart of nephrologists all around the world. And that wraps up this web episode with hopefully what is some interesting medical history for the viewers. Please tune in next month for another video. As always, subscribe to the YouTube channel to find out when we're releasing more videos. And thank you for watching.